transition, but the overall picture is not going to change. I'm still going to be doing the neuropath for most of these cases. There'll just be sort of a broader range of things available and materials available and more data as time goes on. So as I mentioned, the University of Iowa had the current iteration of the brain bank here dates to me starting in 2017. There was a brain banking effort here in the late 1990s, early 2000s that was housed in psychiatry that fell sort of into abeyance in the early part of this century. It's kind of funny to say that, but those brains were fixed in formalin and are currently housed in my lab. There's some sort of there's an ongoing effort on the parts of collaborators of mine in psychiatry to build up a sort of some metadata, better clinical data on some of those samples. But what I'm going to be talking about is the cases that have been accrued since I started here. So our sort of efforts in obtaining tissue are based in the Decedent Care Center here at the University of Iowa Hospitals and Clinics. We have a mortuary facility over in the General Hospital that has capacity to do up to 4 autopsies at once. It's staffed by 3 forensic pathologists, 4 neuropathologists, including me. And then we have 5 hospital morticians and 2 administrative staff members. And this is one of the 2 main rooms on a unusual day when there's nothing going on. Our autopsy service houses or does hospital autopsies for the University of Iowa Hospital and Clinics. So these are patients who die usually in the hospital, although not always, where the family is providing consent and the family is asking for an autopsy to be performed either for education, research, or teaching purposes. We also provide forensic services to Scott, Muscatine, and Johnson counties. The Johnson County Medical Examiner is based here, and the Chief Medical Examiner is actually on the faculty here in our department. And that office is certified by NAME, which is the certifying body for medical examiners, which is actually quite unusual for a county of this size. We also do neuropath consultation for the Iowa State Medical Examiner, which is based in Ankeny and covers most of the rest of the state. As an aside, I realize that as pathologists, we have a reputation for being creepy. Igor is not a member of our department, and none of the hospital morticians look like this, although they occasionally have a very Igor-esque sense of humor. So there are a couple of things that often get asked that I sort of put into a slide up front. So for the tissue we have in the brain bank, for all of these cases, we have consent from the next of kin, and the consent includes donation of tissue or retention of tissue for research, teaching, or diagnostic purposes. So that part is covered. We, unlike Donna and Mark, we worked exclusively with deceased patients. So our efforts are exempt from IRB review. We have a human subjects research determination from the IRB, which has said that this is not human subjects research. And when I ask them about it, they basically tell me to leave them alone. We can provide demographic and clinical information, but all samples that we give out are de-identified. So receiving researchers do not need an IRB because this is, again, not considered human subjects research, A, and B, the samples are anyway de-identified. We do have limited amounts of fetal brain tissue in accordance with Iowa law and federal law. We have, the tissue we have is from miscarriages and perinatal deaths only. So these are cases where we have consent from usually the mother for retention of tissue for research. And we don't have a lot of these cases, but we do have some in the brain bank currently. So the types of cases that we have and that we accept, we have routine hospital autopsies. So as I said, these are patients who die in our hospital here, and the family requests autopsy for any one of a number of reasons. A lot of these are control patients. We do have some increasing numbers of neurodegenerative patients coming in through this route. And most of our pediatric and infant cases come in through this route. So for these, the consent is part of the process. and is part of the autopsy consent process. We also have some pre-consented autopsies. So these are patients usually with a chronic disease, usually again, but not always adults. And these are cases where the patient themselves consents to autopsy before death. And these are all usually patients who want to specifically donate their brains to the brain bank. So they're not necessarily interested in a diagnosis because often they already know what the diagnosis is. They're doing this to benefit research. We save the consents until the patients pass away. That can be years. We never get rid of them. And then when the patient dies, if it's out of state, or if it's out of the hospital, the funeral home generally will transport the body here, and we get the brain through that route. The third group, which is sort of the rarest right now, but we hopefully at some point will be able to expand this, are forensic cases. So these are cases that are autopsied under the jurisdiction of the medical examiner. These are, so the first two categories have to essentially by definition be natural cause of death. So in other words, complications of natural disease. Accidents, suicides, homicides, have to go through the medical examiner system. In this case, the consent for autopsy is provided by the county medical examiner, not the family. That does not include consent for research. So for these, we have to go back then after the fact and get consent for research, which is why this is not something we've been doing a lot of, just because logistically it's difficult and very time consuming. So the basic workflow, which has gone through a few iterations, this is sort of the product of a lot of adjustments and development over the last 3 years, is when the brain is removed in the decedent care center, it's divided in half sagittally. So we operate under the generally, but not always valid, presumption that the two sides of the brain are largely equivalent. There's a few neurodegenerative diseases where that's not the case, which can be problematic, but it generally is. One half of the brain, which you can see up top here, and this is actually one of our cases, is then sectioned. So it's divided in half. It's then, the brainstem is removed with the cerebellum. It's sectioned coronally. And we then separate out certain key areas that researchers frequently ask for. So we get a lot of requests for things like hippocampus, which is here, anterior hippocampus, basal ganglia, cortex, and so forth. The remaining tissue, which does not fall into any of these categories, is saved as a whole piece. So if somebody asks for something like hippocampus or cerebellum, we have our standard list of sections, and that's pretty easy to pull. For more unusual areas, that can also be done, but requires a little bit more time and effort to do the dissection. The other half of the brain is fixed in formalin, which is why it looks like it's a different color here. It's again sectioned, and this is the half of the brain that we do our pathologic workup on. So we submit sections. The sections are the brain and the sections are examined by a neuropathologist for diagnosis. And the exact sectioning is going to vary a little bit based on the nature of the case. But what we have then is formalin fixed wet tissue and paraffin blocks that you can cut slides off of for staining. So essentially the sort of outcomes for this are specific anatomic regions, which are frozen as aliquots and can be given out relatively quickly, slabs, which require additional dissection, and fixed wet formalin fixed tissue, and paraffin blocks. The things that we're sort of expanding into with the new neurobank, which I'll touch on at the end, are other fluids, so specifically CSF and blood, and fibroblast culture. So that's again an area of active development. But basically what this means is that you have access to fresh frozen and fixed tissue from well-characterized brains. We know the clinical history. We know what the neuropathologic findings were. If it's a neurodegenerative disease case, we have an autopsy-confirmed diagnosis, and we can essentially pull the same area of brain from contralateral sides, frozen and fixed. So we'll have hippocampus here. We will also have hippocampus here, which allows correlation of findings. You know, if someone wants to do mass spec or RNA-seq, which you need frozen tissue for, you can then match that up with some histologic test or staining or whatever on the contralateral side. The tissue blocks, what we usually do is there is a core facility here, the Comparative Pathology Laboratory, which is staffed by research histotechs who can do the actual cutting of blank slides. They can actually do staining for investigators if they're interested, or if they just want the slides and do the staining themselves, they can the core can do that for folks. And then for these, again, this is just frozen tissue that can be given out in aliquots. So as of now, we have a total of 50 cases. This is actually expanding rapidly with the Neurobank being established. We have a lot more, we have more capacity, and like I said, thanks to Dr. Abel over in the INI, a significant amount more funding. The current cases we have are a little bit of a grab bag, but we have the largest group are healthy control subjects. So this is all the way from premature infants and fetuses all the way up to people in their 90s. We have some cases of Lewy body dementia. This is sort of an unfortunate development of recent events, but we do have fixed tissue, at least from COVID cases. We don't really have the facilities to freeze large amounts of tissue from potentially highly infectious cases. And then we have things like Huntington's, Alzheimer's, other neurodegenerative diseases, and then, like I said, a few sort of oddball cases. We have cerebellar agenesis, for example. But what we're trying to do is we collect cases that are sort of generally useful, like the healthy controls. I do a lot of developmental neuropathology in my lab, so I use a lot of the pediatric and infant tissue myself, and have shared that with a fair number of other people as well. But what we try to do is sort of tailor this to individual research group and clinical cohort interests. So we have Huntington's disease because we work with Pagnopoulos in psychiatry, who has huge Huntington's cohorts. The Lewy body dementia and Parkinson's cases are mostly through Ergun Uch and Kumar Narayanan and Georgina Aldridge in neurology. ALS would be Dr. Swanson, also in neurology, and so forth. But again, the ultimate goal here and that we've been pursuing is that this has some element of a plug and play interface, so that if a particular group is building a research study on a cohort and wants to add a tissue-based component, that we can essentially provide appropriate letter of support and so forth, and those brains can then come into this established network and core without having to reinvent the wheel. Because one of the problems that a lot of institutions, including where I trained in New York, is you have multiple groups doing this sort of work, and you end up having the same brain bank problem being solved 4 times by 4 different groups, and it causes utter chaos, especially when you're dealing with things like getting controls. So the idea here is to centralize this and make it accessible to people who are not pathologists and may not ordinarily have the ability to work with human brain tissue. So we've worked with and shared tissue with people in multiple departments across the institution. Hans is the representative up here. We've shared multiple samples of cerebellum with his group, and then different regions of brain based on interest. Cerebellum with Celine Williams in psychiatry, a couple of folks in neuroscience and the new Department of Neuroscience, Pharmacology, Neurosurgery, Pediatric Neurology, and so forth. The idea is that this is supposed to make it easier for groups who don't generally work with human tissue to validate results coming from their other work in human tissue. So if someone wants to go that extra step to bump that paper up a few extra impact factor points, we can help do that. For folks who are trying to put together a project and want to add that extra component, that we can help with that as well. As I said, sort of the transition state here, this is transitioning into this larger neurobank, which Quina is going to be running, and this will actually include both human tissue from autopsy. Eventually, likely will also include surgical samples, which are limited, as well as things like fibroblasts and fluids. The one exclusion there will be we're going to, so malignant cases, so brain tumors, gliomas, are continuing to go to through the tissue procurement core at our department and through the cancer center. So this is focused on benign cases. Obviously, most of the tissue will be autopsy, but there will be some from neurosurgicals, and the idea is that all brain or neuroscience related human samples that are not tumor will ultimately sort of go into this central repository with which will help people add this component to their research. And, obviously if someone has a huge cohort study and they're feeding tissue into here, we're not going to give it away to their direct competitor without asking. But the idea is to facilitate research using human tissue and human-derived materials in neuroscience. And like I said, there's been a few people added. So me, Queena is sort of the overall director, and then Asleen Williams is in psychiatry and does stem cell work. So she's been helping get the fibroblast component of that up and running. And the really cool thing about that, it does sound vaguely Frankensteinian, but you can actually take skin or dura from a deceased patient within 6, 12, 24 hours of death, and the fibroblasts are not dead yet, even though the person is. So you can actually culture those fibroblasts and derive stem cells from that, and which essentially gives you the ability to have a piece of tissue from a deceased individual in your test tube or on your slide, and you can, in theory, have a cell from that same person that's alive sitting in a tissue culture flask, which is kind of cool and not something that's new and not something that really has been available in the past. So, as creepy as that sounds, it actually has a lot of potential for allowing true experimental studies in human postmortem tissue, so to speak. And that's about it. That's essentially it. So basically, like I said, the main people to thank for this are my department, which sort of has put up with me doing this for the last couple of years, the forensic pathologists who put up with me asking if I can collect brains all the time, and then Ted Abel and Queena for sort of spearheading this development into the Neurobank.
Wow, fascinating presentation. I had no idea that you were doing all this, but what a wonderful resource, potential for future related studies.